This episode of EMS One-Stop is brought to you by Lexipol, the experts in policy, training, wellness support and grants assistance for first responders and government leaders. To learn more, visit lexipol.com. That's Lexipol.com. Hello and welcome to this very special edition of EMS One-Stop. I'm your host, Rob Lawrence, and I'm reporting for this show from the North Carolina EMS Expo 2024 here in Greensboro, North Carolina. It's actually the second time I've been here. We were here last year, and we were on the escalator, we were everywhere, we were recording some amazing content with some very, very smart and intelligent people, and we're looking forward to doing that again. And we're going to bring you some some top tips from the folk that are here at the conference. First person I spoke to this morning was Matt Streger, EMS lawyer, who's also in town for the conference, talking about some of the leadership content that he's delivering. Let's have a word with Matt. Joined by EMS lawyer extraordinaire, Matt Streger, here at the North Carolina EMS conference. What are you talking about, Matt?
Rob, we're doing actually our Leadership Enhancement and Development program as a track here. It's the first time we've ever run our 16-hour program at a state EMS conference. And to meet the conference's needs, we broke it up in a unique way. We did part of it as a pre-con and part of it as breakout sessions, so people can come to either or all the different parts as they want to. They can take the whole 16-hour track and get the whole certification when they're done if they want to do that too. And they can still go and see the plenary sessions like Matt's keynote this morning. Yep. It doesn't interfere with that.
So we don't have 16 hours to chat. Well, maybe we do, but if you had to break it down into maybe the 4 or 5 key learning points, and obviously the 4 or 5 key takeaways that students would benefit from your class.
Yeah, we actually have 4 modules, so that works really well.
Right.
We do just culture, incident investigation piece one day. We do an HR issue spotting, supervising former peers the next. We do a leadership communication, mission, vision, values, conflict resolution, and we do employee engagement, power, and influence. So those are really what the 4 pieces are, and it's all tool-based. The thing that I think is really important about this is that it is as much theory as practical. Yeah. The line I've always heard is, if all you've got is a hammer, everything is a nail, and you just go around and you hit things. We try to give tools. We try to give extra tools and the mindfulness of when to use them in your toolbox.
So last year's EMS One survey came out, what paramedics want. Leadership got I'm going to be quite rude here, got a hell of a kick in.
Yes.
Right, obviously we need to focus and pay attention to development of leadership and development of, you know, if you had to give your 2 top bits of advice now to emerging leaders, what is it?
Invest in yourself. Go to the conferences, professional development, the Stephen Covey line of sharpen the saw. Go to places, learn, take Coursera courses, go get a degree, go and be a discerning consumer at these EMS conferences of the sessions you go to, and take those things and develop your personal board of directors. Honestly, it's a Ray Barashansky line. I'm going to give him the shout out here while we're on video, but he's the one who coined that phrase, and I use it in every one of my programs. The people that are successful have surrounded themselves with people who give them hard advice, people who are their sounding boards, their moral compass, their crisis managers, their emotionally intelligent people who they can bounce things off of before they make a decision, because sometimes it's hard to unring those bells, and having that in advance, I think, is the hallmark of the good leader. That's, to me, one of the things that we teach in this class, that I teach in my class especially, it's in one of my modules, that people come afterwards and they're like, that's my take home. That's, I think, what people's take home should be.
Excellent. Matt Streger, I'm sure we'll hear from you again soon. Thanks very much.
Thank you, sir. Appreciate the time.
So joined by a friend of everybody, Kevin Collopy, here in North Carolina. What are you working on right now?
Well, Rob, thanks for having me back. It's wonderful to be back on. Getting ready this afternoon to speak on a presentation that's really 2 years in the making. I think many people remember the name Sean Killian. A little over 2 years ago, it started with a phone call. He said, hey, you interested in doing some work, doing trauma training in Ukraine? Not knowing any better, I said, joking, like, is this for real? And 2 years later, we have trained over 1,000 pre-hospital providers, 5,000 clinicians across the country, and have had 2.7 million views on translated videos, all focused on providing just-in-time trauma care to the Ukrainian health system.
So Ukraine, we actually have been working with Ambulances for Ukraine. The American Ambulance Association is sponsoring them, and we're trying to help get vehicles over there. Obviously, that's the vehicle side, and you're providing the medics to go in them then.
Yes, so we aren't providing actual medics. What we are doing is we are taking the
training.
The training, yes.
Right.
So what happened in the onset of the war is many of the existing paramedics were also working for the military, so they were brought to the front lines. Other EMS systems and their ambulance providers were brought to the front lines, leaving a vacuum behind of appropriately trained providers. And at the same time, we've seen a huge influx of injured civilians. Through February 15th of this year, there have been over 19,000 civilian casualties because of the war. So there's been a huge need for trauma training for everyone who is now working on the ambulances. So we were ultimately hired through International Medical Corps from the Ukrainian Ministry of Health to provide this training for pre-hospital providers, physicians in the hospital, nurses in the hospital, and we've created 7 course streams. And today I'm going to be talking about the pre-hospital arm of that program.
Wow, now have you been over to Ukraine yourself?
I was over there in January.
And so what are your impressions of not only of the training you've delivered, but actually the morale of the people, and the state of the place, really?
So Ukraine is probably one of the most beautiful countries I've visited. The people are some of the most passionate, positive, and resilient individuals you could possibly meet. I was there for 10 days in country for 8 days. During that time, I was woken up at night because of all country air raid sirens 5 times. I felt the fatigue on me in a week of that.
Right.
The folks I was teaching how to teach our program have been dealing with that for 2 years. And they're still positive. They're still looking out for their country. They still believe in maintaining their independence, and they will do anything to help each other. And it's probably one of the most inspiring groups you could possibly work with in the world right now.
Wow, that's remarkable. And obviously the program continues.
Yes. So we started this program through Harvard Humanitarian Initiative with the end in mind. So we knew if we went over, created a bunch of classes, did a bunch of training, we would have an impact. Well, what happens when we leave? What happens when the courses are over? And so from the beginning, we wanted to create something sustainable. So we've had 4 phases of our program. And in the first phase, we were over teaching. During that time, we were looking at our Ukrainian partners through our translators and trying to pick out who would be good instructors. In phase 2, we started training those instructors and having them teach our courses. In phase 3, which ended in January when I was there, we had our Ukrainian faculty teaching with our American instructors, monitoring, listening, really providing support and guidance, but still running the classes. Now in phase 4, our Ukrainian faculty are teaching independently. They're running the courses, they're planning the courses, and we're just there on the sidelines in case any hiccups come up. And really watching them, and now when the program ends and we really aren't there anymore, these courses will continue to be taught and to continue to have impact on both the providers and the patients throughout the country.
Well, thank you for what you're doing there. Clearly, it's making a big difference. You mentioned Sean Kivelham.
Yes.
And I've got Kevin Collopy here, of course. One of the other things you're famous for in the United States is developing and bringing on the next generation of national conference speakers in Stand and Deliver. And actually, we've spoken about it before, we've podcasted about it before, we've written about it before. I never tire of it. Is it coming back this year?
Stand and Deliver will be back at EMS World Expo in Las Vegas this fall. We are thrilled for it to be coming back and thrilled for this year's sponsor, the International College of Advanced Practice Paramedics. They were thrilled at the opportunity to have to participate in sponsorship of it. Once again, there will be 4 rounds of 16 potential new speakers who have never spoken before at conferences. And then the winner of this year's conference will be speaking at EMS World Expo in 2025. If you can already believe we're talking about Expo 25.
Wow. Now, we've had some amazing winners that have gone on to actually have some great speaking opportunities around the country. But pick out some of the winners and, where have they gone on to from there?
So I think one of our winner for this year, Miss Conley, who's going to be speaking at EMS World Expo in Las Vegas, she's probably one of my favorites because she could have presented 2 years ago.
Yep.
She was the runner-up at Stand and Deliver 2022 and was just nudged out by another phenomenal speaker. And she came back this year, she polished, she worked on it again, and just blew our socks off a second time in a row. And her tenacity in coming back, wanting to get better, applying the lessons learned from the judges that were giving her feedback, really showed us that our next generation of EMS educators is in good hands, and that when we kind of hang up the microphones and we pass the baton aside, we've got even better speakers tomorrow than we've had today. So I think of all the great speakers that are out there today, the people I want to aspire to be like, the Ray Baryshantskys, the Matt Streigers. Next year's generation is going to have even better speakers.
Excellent. So better than the edutainer that is Ray Barashansky. Yeah, I look forward to seeing that one. But we love you, Ray. I was actually a judge on her and then the final, obviously, last year. And I'm looking forward to seeing these folk that have come through speaking at the main audiences. That's exciting.
Yes, and it works out. Rebecca is in her hometown, so she doesn't have to travel very far in Las Vegas. She's actually from there and works in the EMS system there. And I have a feeling you guys will see her at conferences for years to come.
Rebecca Carmody, by the way, and spoiler alert, actually from my front door to the back of the convention center is a 10-minute commute for me, so I'm looking forward to it even more than anybody else.
Might take longer for me to get from my hotel to the convention center.
I think it will. Anyway, Kevin, thank you so much. Final Rob question as always. Anything I need to ask you or anything you forgot to tell me?
Just that we are really excited to begin talking about the Ukrainian story.
Yeah.
We'll be presenting on this topic at the Metro Carolina EMS Conference in a couple of weeks at FAST 2024, which is in my hometown, Wilmington, North Carolina. And Sean and I will be co-presenting on it at EMS World Expo. So if you'd like to learn about the project, please come to one of the conferences, come hear about it, and I'll give Rob the website link so you can look up the
details in the show notes.
Yep.
As always. And actually, while you're here, do a plug for future speakers that might want to come and do Stand and Deliver.
Yes, so
look over there and tell them.
If you want the opportunity to come speak at a national EMS conference, but you've never quite been able to get through the door, Stand and Deliver is your opportunity to get spotted by some of our expert speakers across the country and throughout the world. Sign up for Stand and Deliver 2024 in Las Vegas, Nevada during EMS World Expo. You do have to be an attendee of the conference. You also have to never have spoken at a national EMS conference before. So we truly are looking for the novice up-and-coming speakers. Registration for Stand and Deliver will open sometime in July on the EMS World Expo website. So watch our social media, watch the website, watch for information to come out for it, and come have a wonderful time and walk away. Whether or not you're the winner, you will be a better speaker because of the feedback you get.
So before we go any further, let's have a quick word from our sponsor.
Lexipol empowers first responders and public servants to best meet the needs of their residents safely and responsibly. Serving more than 2 million public safety and government professionals in over 8,000 agencies and municipalities, Lexipol offers a range of solutions that includes policies, training, behavioral health resources, news and analysis, and grant assistance services for law enforcement, fire and rescue, EMS, local government, and other agencies dedicated to public safety. To learn more, visit lexipol.com. That's LEXIPOL.com.
So back in, the topic is blood, and I have with me Dr. Randall Schaeffer and Dave Grovdahl. And first of all, Dr. Schaeffer, give us your backstory.
So I am a retired Army trauma nurse. I spent 20 years in the U.S. Army.
And thank you for your service.
Thank you, and thank you for yours.
Thank you very much.
And during that time, I unfortunately had to use blood quite a bit on my 3 deployments. And I took what I learned on those deployments and that military experience and brought it back when I retired to South Texas, and I helped set up the South Texas Regional Advisory Council, their pre-hospital blood program to the aircraft and the ground ambulances in the area. And I developed an onboarding process, which is hopefully a common sense approach for EMS to take as they try to start rolling out these programs. Because as David knows, it's a largely unknown task. There weren't any EMS agencies to do it, so they just needed someone to help them through it. And that's what I do.
Excellent. Before we dig into this, Dave, would you like to introduce yourself? I know who you are, we know who you are, but...
My name is Dave Grovdahl. I am a 25-year paramedic, and I am the director of EMS for a hospital-based system in South Central North Carolina.
So blood is being rolled out across the country, which is a good thing. This time last year, Dave, you gave me a very simple answer that if it comes out of a person, we should just have it there to put it back in again. I think that was your answer.
Absolutely. Whole blood saves lives.
Whole blood saves lives.
No doubt about that. And so it is probably the greatest improvement in trauma care in the civilian world. And so we are trying to spread the message as far as we possibly can from coast to coast.
Right. Now, you said... I think I said it's everywhere, but it's not everywhere yet, is it?
It's not everywhere. Right now, we're currently tracking 150 ground EMS agencies that are utilizing it, and it is largely portioned off to certain parts of the U.S. There are some barriers to getting programs stood up, but we have had 150 successfully tackle it.
Excellent. Are there any sort of blood deserts out there that we need to sort of encourage folks to do better?
Yes, unfortunately, we have a lot of blood deserts. So in states where paramedic scope of practice does not allow them to initiate a blood transfusion, that is a barrier that needs to be overcome. But there are states that are successfully overcoming that barrier. And then others are facing challenges with getting blood sourced. So we have had some amazing blood centers step up, hospitals step up and support EMS, but unfortunately that's not happening across the country.
Right, so over to you, Dave. You've been running a program for, well, I guess over a year now, because we spoke about it last year. And so how's it going, and what results have you seen and outcomes?
We've had some really fantastic support in North Carolina. North Carolina is a great state in the fact that we have both coast and mountains. We have both urban and super rural areas of the county, of the state. And we have blood all throughout. So we have urban centers like mine where we have blood going. We also have some rural areas where we know that trauma, the mortality rates from trauma are very high in the rural areas just because of access to hospitals and access to care. So we are getting blood into those areas where it is most critically needed. And so North Carolina has really made some great strides in a very short amount of time.
So clearly this is going to end up in an appeal for everybody to give blood. Apart from us Brits, we can't give blood because apparently we may have some sort of mad cow disease.
That waiver has been in place now. It just got approved.
Really?
It is,
Oh,
yes.
I've been rejected by so many blood bank wagons you wouldn't believe.
I will clarify, for the U.S. forces in Germany, I will have to double check and make sure that
Right.
the Brits...
No, I can't give blood here, which is
It's unfortunate.
mad cow disease. May have it, you never know. Anyway, so let's talk about, so I'm a logistics guy, right? And of course, the one thing that struck me straight away is if we all do blood, it's a good thing. But if we all do blood, it's a lot of blood we have to have prepared, delivered on the truck, then a plan for its rotation or possibly its disposal, etc. So what do we need to think about when we're getting a program together? And where do we get it from?
Absolutely. So the logistics are the challenge. The science is coming with the why. Why do we need to do this? As far as the how, different models are emerging across the country on how they best tackle it. And even here in North Carolina, we have along the Blue Ridge Mountains 3 different agencies that are doing pre-hospital blood, and they are all doing it a little bit different to meet their logistical needs. One gets supplied directly from a level 4 facility, so not even a large trauma center, just a small facility that is willing to share their packed red blood cells right off their shelf at the agency. We've got blood centers that will ship blood into the area, and then we also have a level 1 trauma center that is really the center of gravity for 3 other agencies by providing them a cooler every 5 days with blood products. So it goes out to the agencies.
And then it's rotated back in?
And then it's rotated back.
Excellent. So, but Dave, I think before we started recording here, there are other programs where we're asking our public safety brethren to actually be a part of the program in terms of donation.
So in San Antonio, where whole blood program really got some feet underneath it, they developed a program called the Brotherhood. And so we know that low titer O positive whole blood, which is the blood that we use, is most prevalent in the adult male population. And so it got that title Brotherhood. What we found when we started replicating those was as systems are using whole blood and they make appeals out into the community to say, the blood that you donate today may be on the ambulance you see at the intersection tomorrow, and potentially will get used on a family member or a friend. People have really stepped up to say, I'm going to support my community. We see that a lot of times after disasters. People turn out in droves to support their community. This is the same thing, and we have had great response when we tie the whole blood programs for the ground ambulances in the community back to the donation, and that has very much helped the blood centers get more of that blood.
So, yeah.
And I would also add that we are starting to show that if you get pre-hospital blood and you're coming in with an improved shock index, improved vital signs, that your consumption of products when you arrive to the hospital actually goes down. So we're getting to them earlier, faster, thereby decreasing the requirement when they arrive to the hospital.
That's excellent news. Now, you're delivering a session here at the North Carolina EMS Expo. What's it on?
So I had
As if we didn't know.
Yeah. Spoiler alert, it's about blood. So I had the opportunity last year to come to North Carolina and meet agencies and learn what they're doing, and I wanted to tell their story. So I worked with them, and we submitted an abstract talking about how do they source their blood, what are their protocols, what are the equipment that they're using. So I'm privileged that I get to facilitate a panel, and we have Surrey County EMS, we have Caldwell County EMS, and we have Wilkes County EMS, along with Christina Warren, who is a unicorn in the blood banking world. She said yes to EMS, which is more important than saying yes to the dress, if you know that show. She said, yes, we need to support EMS, and that's not happening everywhere in the US with the blood bankers. So we are all gonna sit down and just have a great discussion about how they're doing it and how they're successfully doing it.
So I wouldn't be me if I didn't talk about politics and funding, right? And so, of course, ambulance services reimbursed only for transporting a patient to hospital. This is happening in the field. We're not getting paid for it yet, are we, Dave?
We are not. We have a national coalition that is working at the federal level in order to get whole blood recognized as an ALS2 intervention. I think that's going to, when that happens, it's very much going to open the door because the reimbursement will match the costs. And we also have a lot of coalitions from state to state. Florida has a coalition, Texas has a coalition, North Carolina has a coalition. So we are all working at our statewide level in hopes that we can put enough pressure at the federal level in order to get that change. And I think it's just a matter of time before the dominoes fall.
Certainly, I've certainly been up with NAMT and the AAA in the last few weeks, and obviously treatment in place and therefore ancillary treatments such as whole blood in the field were up for discussion. You know, in certain states, I live and work in California, of course, you know, $200 and something for a Medi-Cal reimbursement doesn't cover, what is it, $800 for the blood? So we need to work on this, and now.
Absolutely. We know that whole blood saves lives. I mean, that is the basic premise. And so EMS is well positioned to be part of that process. Like Randy said, when EMS gives whole blood, the patient does better over time, as well as they wind up using less blood product. And so it makes sense. And you know, that's step one is we've got to make a strong, salient argument, and I think we have a very good one.
So for folk that are thinking about introducing this into their system, introducing this into their protocol, what do you say to them?
It takes commitment.
Right.
And I would say that this is the only clinical intervention that EMS does that requires so many stakeholders to get accomplished. You have got to talk to your hospital. You have got to talk to your blood centers. If you have a regional advisory council, get them involved. You know, if David buys a new defibrillator, he doesn't have to go to the hospital and ask permission and have cardiology oversee it. You just do it, right?
Correct.
But you can't do that with blood. It's a team sport. You've got to get a lot of stakeholders involved.
So, and finally, you've got a paper coming out. What is it and where can we read it?
So the paper is called Removing the Barriers to Prehospital Transfusion, a roadmap to success, and it will be in the Journal of Trauma and Acute Care Surgery, where we outline the state of affairs in the U.S. about prehospital blood and offer some solutions on how to get there.
So an important topic. Hopefully once it comes out, I'm sure Dave will tip me off and we can get it published and where everybody can read it.
Absolutely.
So thank you both very much for this very important discussion. So excited and delighted to talk to Peter Dworsky from the National EMS Safety Conference. And Peter, you just had a conference in Denver.
Yes,
and,
we did.
So how did it go? What were the highlights? Who were the keynotes? What were the takeaways? Four-part question.
Four-part question. So it was in Denver. It's in Denver every year. This is the 16th year we've had it. We get about 50 to 80 attendees. It's actually a very focused conference, highlighting safety issues in EMS, transportation, patient safety, quality assurance issues, but the targeted audience is focused on the safety professionals within EMS. So it's not a clinical-based, per se, conference. We're not talking about bleeding control. We're talking about the safety mechanisms an EMS system can put in place for both their providers and their patients.
So we spend a lot of time talking about the culture of safety, but
yes, we do.
And we've talked about that for a long time. Obviously, you've just had the conference.
Yep.
I mean, what are the big themes that those watching, those listening out there operationally now need to be thinking about?
So the biggest focus of the conference was driver safety, and reducing the use of lights and sirens and everything that goes along with that. How to reduce the collisions and make it safer for the employees and the motoring public.
So I actually maintain the media log for the American Ambulance Association, and one of the things that we collect is traffic collisions.
Yep.
And also ambulance thefts.
Yes.
And I have to say, and I've been on a bit of a soapbox / crusade / whatever you want to call it about particularly ambulance thefts. Inevitably they are taken from outside a hospital, they're taken with vehicles that don't have immobilization devices, they're taken from vehicles that maybe the crew have gone in quickly with a patient, doors are open. I mean, the answer is obvious, but what's the answer?
The answer is the obvious answer.
Yep.
Lock the vehicle, take the keys. It's actually was a Homeland Security directive about 7 or 8 years ago not to leave emergency vehicles, fire engines, police cars, and ambulances unattended with the keys in them.
Sadly, we didn't pay attention to that.
No, we don't, and we paid for it.
There was a period, certainly at the end of last year, where it was almost a weekly event. I despaired every time I opened up the Google tracker we had, and there's another one.
There's another
one. There's another one.
Right. And it's not just the theft of the vehicle that becomes problematic for the EMS agency. It's what that person does with the vehicle. All the carnage and damage that then follows.
Yeah.
Because very rarely do they just pull them over, park them, and leave. There's always something that occurs.
Don't. And actually, I saw certainly last year a number of incidences where the cops had to deploy the spike strips.
Yep.
Somebody attempted a pit maneuver on an ambulance, and actually that's a big vehicle to try and flip and turn. It's dangerous.
Right. And I'm sure we're coming up on the anniversary of the paramedic in New York City who ended up hopping out of her ambulance because somebody was sort of surfing on the tailgate of it.
Yep.
And then when she went around one side, I believe, he went in the other, and the keys were in the vehicle, and she ultimately died from that incident.
It's very sad.
Yep.
Sadly, the solution, though, is very simple. Either lock or immobilize. And actually, I've certainly done the research. For about $130, you can buy a device that will immobilize the vehicle to a degree that only the operator knows how to actually activate it and operate it.
Right. I mean, it even becomes more simplistic than that. You can put in an override button in the vehicle. One service I worked at, the mechanics, aftermarket, put in a device. I put it in park, push the override button, I can take the keys out to leave the vehicle running,
right.
But you can't put the vehicle into gear.
Kussmaul system, exactly. Now,
Yep.
Of course, at your conference, you had Doug Kupers. You said you talked about lights and sirens, obviously. Kupers, Redlener, Taigman, et al. Have published a lot now on reduction of lights and sirens.
Correct.
Are you sensing it's actually being reduced?
In some areas, yes. We've had lots of success stories. We need to start changing the mindset of 3 groups of people, I think. The people actually driving the ambulances.
Yep.
Nobody gets into this profession because we just want to drive somebody's grandmother from the nursing home to the hospital. We want it to be an emergency. We promote this as an emergency, but sometimes it's just a ride to the hospital, and that's all it needs to be. We need to get administrators on board with the knowledge that they're going to get some pushback from the community and the politicians that we're not driving fast to calls. And then we have to change the patient's perspective of just because you call for an ambulance doesn't mean it needs to be there in 10 minutes. You've had this problem for several hours now. It's okay to wait 5 more minutes. When I would teach safety classes and I would teach the providers, it does you no good to get halfway there really fast and then crash.
Right, and actually I've been talking to a number of folk about the fact that we've got the research done, we've got the data there, we've got the papers published, That's great, but the flip side now is those that commission us, those that regulate us, those that employ us, as in local governing bodies, local authorities, have to understand that we are doing this for actually the reason that saves crews, saves vehicles, saves pedestrians, saves lives.
Yep. We reduce the collision, we reduce the money outlay, and we have the money to use for other things that we can now.
Excellent. So Peter Dworsky from the National EMS Safety Conference, thank you very much. And so do you want to plug, do we know when next year it is, the dates?
Off the top of my head, I believe it's the first week of April next year in Denver.
Okay, so if you are a safety proponent, or indeed if you want to attend an excellent conference in Denver, pop along to Peter's conference, National EMS Safety Conference. Peter, thank you very much, sir.
Thank you, Rob.
Well, thank you very much for joining me at this very special edition of EMS One-Stop. Back to the studio, back to the Zoom next time, but for the moment, live on scene. I've been Rob Lawrence. This has been EMS One-Stop. Don't forget, like and subscribe. Until next time, bye for now.